Hey guys, Andy Austin with the Bald MP, 19 years interventional pain management practice as a nurse practitioner. We're going to put out a video today talking about the two most common causes of pain. This is going to be important for folks that suffer with chronic pain and folks that treat chronic or acute pain. A lot of times what we'll have patients come and they're really upset that they don't think that their pain's been effectively treated like they feel like it should. And sometimes they're correct, it's been undertreated. And a lot of times the patient's not exactly clear on what type of pain that they're having. So that's why I wanted to put this out. So maybe you learn a little bit and help you kind of get an idea of what your healthcare provider is doing whenever they're trying to help you. At the end of the day, they're trying to help you, right? So there's two types of pain, nociceptive pain and neuropathic pain. Now, there's a lot of different subclinical compartments of each, but we're going to stick with the two main causes of pain, okay? And there's different medications depending on which type of pain that you have, okay? And a caveat to that, pain is treated multimodal, which means hitting it from all different angles, right? There's not one single bullet that'll fix everything, unfortunately, right? So we're just talking about medication here in this video, but you know, it's always good to get physical therapy involved, interventional pain or orthopedics involved when you're talking about musculoskeletal pain, and also get to the root problem, what's causing the pain. You have a good, clear, accurate diagnosis of what's causing the pain, okay? So that's all in that huge process of treating pain, but today we're just gonna talk about the two most common causes, most common causes of pain and the medications that are commonly prescribed for each, okay? So hopefully it'll help clear up some things. So nociceptive pain, what is it? Nociceptive pain is the classic pain everybody thinks all their pain is, okay? Nociceptive pain is an example I give folks is when if you was to go and hit that wall and break your hand, the pain that you have from the fractured bone or torn tendon or something is nociceptive pain, okay? It's related to damage of soft tissue, muscle, bone. That's the type we've all grown up with. As a kid, you're riding your bicycle, fall off the bike, scratch your knee. That's nociceptive pain that you're having, okay? So it has different pathways, okay? So you tailor the medications used to attack those specific pathways, okay? What are the most common causes, medications used for nociceptive pain? Well, number one, it's Tylenol, good old Tylenol. Tylenol. It's very effective for a lot of acute pain. Then, in a lot of cases, you can use anti-inflammatories. What are the anti-inflammatories? Anything from ibuprofen, Aleve, naproxen, basically anything you can buy over the counter that's not Tylenol or acetaminophen are all in the same family as non-steroidal anti-inflammatories. Anything, naproxen, Advil, ibuprofen, Aleve, all that, okay? And then when you go to your provider, what are they gonna prescribe you? They're gonna prescribe you an anti-inflammatory, Mobic, diclofenac, Celebrex, all those types of medications, they're all in the same family. So if you take one, that's all you get, okay? I can't tell you how many times when we see somebody for a new patient, you go down the medication list and they've been prescribed, say, something like meloxicam or something like that, and you start talking to them. They take a meloxicam in the morning, and they take an ibuprofen at lunch, and then they take an Aleve at supper time, and they'll take their meloxicam again at night. No. You get one anti-inflammatory. That's too tough on your renal system, and it's too tough on your stomach, folks. Also too, BC powders, people that take BC powders a lot. I can't stress this enough, guys. Do not take that stuff if at all possible, particularly if you've ever had any type of reflux or stomach ulcers, and particularly on a chronic basis. No, you got to start thinking about the GI system when you start having a long-term use of anti-inflammatories. And it's a real good habit to get into talking with your provider if you're taking anti-inflammatories on a routine basis. Look, I get it. You got to have something. I'm not hating on them. You got to have something to function. You don't want to take dope or pain pills or anything else, but protect your stomach. That's all I'm saying. Talk with your healthcare provider. See, number one, your risk factors for developing any GI problems. Maybe get on some sort of proton pump inhibitor or something else that will help give a layer of protection to the stomach lining. That's a different talk, but that's important, okay? So then after we got on Tylenol, anti-inflammatories, and muscle relaxers, okay? Muscle relaxers, okay. Let me tell you about muscle relaxers. Very few muscle relaxers do what they say they're gonna do, relax the muscles, okay? A lot of the times, muscle relaxers are nothing more than sedatives. I'm gonna tell you right now. Now there's some other ones, like baclofen, that is used, that actually does what it's supposed to do. But our experience is that majority of the muscle relaxers help you relax. And that may, ease the tension of some of the muscles, that type of stuff. But if you have, it's not gonna go to the muscle and make it go away. No, that doesn't do that, okay? So, and then of course, opioids. Opioids are used to treat nociceptive pain, period. Now, everybody's familiar with the current, situation with opioids, and it is a problem. It is a problem, guys. So you have to juggle, try to maintain the patient's functionality as best as possible, okay, on the lowest amounts of opioids, because you're looking long term, okay? There is a thing called tolerance. It is, okay? So you have to balance that. And that's a hard thing to do a lot of times. It is. But if you have a good working relationship with your provider who's helping you manage your pain, it can be done, okay? A lot of times what we talk about is say, look, they have this awful situation. Say they've had multiple back surgeries, okay? And they have multiple levels of facet arthritis in their back. Up front with them, straight up, look, we're gonna manage your pain. We're not gonna take out your pain completely. We're not gonna make you 18 again, I'm sorry. It don't work like that. We're gonna manage your pain, what that means. What that means is we're gonna try to put it in little boxes, smallest box as possible, and put it over in the corner of your life. So you can help go and do within reason what you wanna do while that pain's over there and it's not controlling you, okay? That's the goal, okay? That's the goal. So nociceptive pain. I kind of went long on that, didn't I? Sorry, I'm gonna try to keep these things going. But anyway, second type of pain is neuropathic pain. Neuropathic pain. That has everything to do with the nerves, okay? The central nervous system and the peripheral nervous system. If there's a damage or a malfunction within the central nervous system or peripheral nervous system, i.e. if there's a previous stroke in their brain, you can develop neuropathic pain. The most common cause of neuropathic pain, without a doubt, star this, there will be a test later. No, it won't. But anyway, if it was, this will be a question, is diabetic peripheral neuropathy is the biggest cause of neuropathic pain, period. And that's the burning pain and the tingling pain in the feet. Also, another common cause of neuropathic pain is shingles. There's damage to that peripheral nerve. They have that shingles rash. That virus attacks that rash, flames, causes scars that nerve, and it has that chronic burning pain. Neuropathic pain is kind of like, it depends on what it is. Like, a lot of times it can be at the site of the injury, but also it can affect bilaterally. Okay, so if you're talking about peripheral neuropathy, it's going to affect, it's caused from a systemic problem, diabetes. You're going to have bilateral symptoms in both feet at the same time. You're not going to have one foot having burning pain and another foot not. Typically with diabetic peripheral neuropathy, it don't work like that. If you're having burning pain in the foot, a lot of time in one foot, a lot of times it's nerve pain, but it's from another cause. Is it tarsal tunnel syndrome? Is it sciatica? Is it something else? Okay. Other causes are the tumors, CVA, diabetic peripheral neuropathy, alcoholism, when there's damage or insult to the actual nervous system itself. And what do we do? What do we use to treat? Medication-wise, we're talking about. We're going to be talking about the anti-seizure medications. Those are the Lyricas. Those are the gabapentins or Neurontins. They were originally made to treat seizures, and they found out, hey, this works. This helps folks with nerve pain. So they're in a treatment for neuropathic pain. SNRIs, antidepressants, no, we don't think it's all in your head. No. Nerve pain is not all in your head. But antidepressants block a lot of the same pathways of neuropathic pain. Okay? That's what we're treating, guys. All right? Antidepressants such as Cymbalta, duloxetine. Okay? In fact, it has an indication for diabetic peripheral neuropathy. Okay? So if you come in and you're having burning pain and your provider gives you an antidepressant, don't get ticked off at them and they think you're crazy or depressed or whatever you think they think you're going to have. They could be treating you 100% accurate. So, and in the older models of tricyclic antidepressants, Elavils, amitriptylines, those are the things too. So as you can see, compare and contrast, the different types of medications are tailored to what particular type of pain that you're having, okay? And to complicate things, a lot of times people can have both going on at the same time. That's why that multimodal therapy I talked about earlier. We're trying to hit multiple sources of pain. So at the end of the day, you know, there's a reason to the madness, okay? And you need open communication, good dialogue, in a nice way. Ask. Your provider will tell you. They'll tell you, okay? So that's all I got to say about that. I hope that helps. I hope that clears up some stuff. I kind of went long on the anti-inflammatories, I know. But dude, guys, I'm telling you, it's out there. And so just, you know, be mindful of that. You don't want to be treating back problems. You could develop an ulcer, bleeding ulcer. So, all right. I hope you like it. Give us a thumbs up if you like it. I hope you subscribe if you want to. But yeah, keep hanging on with us. We're going to be spitting out some more information. You have a good day. Till next time. Bye.